Hello, good evening everyone. Thank you very much for attending. Welcome to this meeting of the Adults and Health Scrutiny Board. First of all, can I remind everyone to please use your microphones when you speak, because we are being live streamed, and that's how your voices will be picked up. And also, I won't be able to hear you if you don't use the microphones. Thank you very much. Okay, do we have any apologies?
Councillor Pegg.
Thank you. There are no late items. That's correct. No late items. Any declarations of interest? No. Thank you very much. Do we all accept the minutes as a true record of the last meeting? Yes, thank you. I just have a couple of queries, Lindsay, if that's okay, about the minutes in relation to the recommendations we made. One on the mental health care facilities on page 3, about patients placed outside the county. Perhaps their carers should have assistance to enable them to visit their loved ones. And the second one on page 4, the recommendation about the noting and hoping for this future opportunity to discuss the longer-term plans for a 60-day consultation about permanently transferring Ward 1, the mental health services, to the Kingsway site. I just wondered, do we have any responses to those?
No.
Can we expect a response?
Well, I can chase them up for you for the next meeting if that's...
Yeah, that's brilliant. Thanks very much. I didn't know what the norm was, but that's brilliant. Thank you. Okay, right. So our first report tonight then is from Alison Wynne, who's the Assistant Director of Public Health, and she's giving us our regular COVID update. Thank you, Alison.
Thank you, Chair. If you just move on to the first slide for me, Linz. So, brief update on the situation of COVID at the moment, and to be honest, it probably won't be dissimilar to ones that probably many of you have heard kind of over recent weeks. So the slide that's up there gives you an indication of the latest week's case rate up to the end of, or the week ending 30th of October. In the 7 days in that period, we saw 887 cases, which was a rate of 345 per 100,000. And you see kind of the last bar there, that's kind of showing a little drop in kind of previous weeks. Just looking at kind of the most recent data, so just a few days beyond there, we're looking at, I think it's 903 cases in kind of the previous 7 days and a rate of 352. So ticking along around the same sort of area. You'll see, again, from the graph, we've had obviously the couple of steep peaks in previous waves, and you'll see from kind of where we are now over quite a number of months, we've been kind of bubbling along at a similar sort of rate of around about 400 per 100,000, with a couple of ups and a couple of downs, but generally in that sort of range. If you just move on, please, Linz. So I thought this was interesting, just to give you an idea of kind of PCR testing. So that's kind of the testing for COVID. And you'll just see in the last week across, I think, all age groups except for the over 60s, we saw a significant downturn in testing. Like I say, other than the over 60s. If you just move on, Linz. That kind of links to that first bullet there, that we think that is in relation to half term. So we saw a significant reduction in testing over half term week. Early part of last week, so return to school, we did see a kind of upsurge in testing, but that's not kind of coming through in terms of reflecting in notably increasing case rates, but we'll kind of see if that starts to flow through. Cases continue to be pretty broadly distributed across the city. Where we have kind of higher rates, they're absolutely linked to school outbreaks, and particularly in secondary schools at the moment. Kind of earlier in the year, it was kind of more related to primary schools, but linked to schools. So highest rates continue to be in our school-age population, but indication that they then flow through to kind of family members and kind of wider people in the households. We have been seeing increases in the over 60s, so we're at a level now which is about 200 per 100,000 in the over 60s, which is a level that was pretty similar to where we were in January of this year. But yeah, significantly lower than we've had in previous outbreaks. We are continuing to see some people hospitalised with COVID, but that is significantly lower than we've seen in previous waves. And just at the bottom there, for your information, there's an interactive map that's available online, a government provided map that you can go and look at both case rates and vaccination uptake, that takes you down to middle super output area, which is just a bit smaller, or quite a bit smaller than ward area. So if you're interested, you can kind of click on there and kind of see what it's looking like at any point in time. Thank you, Lynn. If you can move on. So in terms of vaccinations, so in the city, so those eligible, which is now those aged 12 and over, we've seen 77% having their first dose and 71% having their second. That is lower than the national average, but higher than most cities, and certainly higher than, or quite notably higher than cities such as Leicester and Nottingham, and also Coventry, Birmingham, so kind of local cities where comparatively higher than those. We do see inequalities in uptake, so there's variation in things like ethnicity, deprivation, so there's variation across the city. And as you'll be aware, the booster vaccination is now available, and we believe that uptake is starting to pick up after a slowish start. There has been a change kind of recently in terms of booking, so you can now book in advance of being eligible. I think it's 30 days in advance of that, and I think that is starting to see people actually booking much more quickly now. So just over the weekend, so these are national figures, but over 700,000 bookings were made just over the weekend using that. And they can be made both kind of online, but there is also now walk-in available, and in the city, that's at Midlands House on Nelson Street. So thank you, Linz. So just a bit of an update in some of the actions and activity that's happening within the city to increase uptake. So there's quite a bit of communications on timing and kind of how to access vaccination, and that's including a kind of range of community languages and targeted drop-off, so letters going to areas where we've got lower uptake. We've got home-based vaccination offered or planned in place for those with severe mental illness, outreach and kind of, well, that's kind of pop-up sites for kind of homeless and asylum-seeking populations, and we've got or had some engagement activity, kind of exploring attitudes around vaccination to the city's black communities, because we've had kind of under or lower uptake in those communities, so exploring that further. And alongside and kind of at vaccination sites, we're kind of using that as opportunity for messaging around kind of winter health and stay warm, etc. So we're kind of trying to maximise those opportunities to get messages across to kind of our vulnerable populations. Thank you, Linz. Next one. So just, I suppose in summary, just key messages. So as you'll have seen from that first graph, whilst we've had kind of a lower rate in the last week or so, it's still pretty high levels and staying stubbornly. So the advice is pretty much as you were, kind of following the recommendations in terms of stay safe, which you'll all be extremely familiar with now. We do have concerns over the continued high rates, and particularly as we move into winter and other issues such as flu and other circulating viruses, and particularly the impact that may have on our health and care sectors. and are continuing to promote vaccination uptake, particularly where we've not got kind of first dose, second doses, and promoting the booster vaccination. So that's a kind of whistle-stop tour of where we are. As I said, it's probably not dissimilar to ones that you may have heard recently. We're in pretty steady state, really. Thank you.
Right, thanks very much. Alison, any questions? Councillor Cooper.
Thank you, Chair. Thank you, Alison. So my first question is around the over 60s. You suggested there that we're seeing a lot more over 60s being hospitalised due to COVID. I saw something on the media, I think it was last night, where they were talking about the possibility where, because that cohort had their jabs really early doors, you know, talking December, January, February, has there been any research, has there been any consideration, is that because they're losing some of the efficiency of the jab, and I don't know what the word is, but you know, is it not working as well because of the amount of time that they've had it, and that's why the booster jabs are coming in?
Yeah, I think that is kind of one of the reasons, and to be honest, it is pretty complex, and we're trying to kind of understand that, and I know certainly hospital colleagues are looking at kind of the throughput. Certainly earlier in the year, it was much younger populations to had been previously seen, but I think it's in part kind of the case rates flowing from starting within the younger population.
Alison, could I ask you to address the mic, please, rather than Councillor Cooper? We just won't pick up what you're saying. Thanks.
Sorry. So yeah, we think it's probably a combination of issues. I think kind of the waning vaccination is one of those, and that's obviously why we're really trying to push through the booster vaccination, and that's really starting to kick in. And whilst I said that we are seeing an increase, it's still, so if we're looking at an overall rate of around 400 per 100,000 for the population as a whole in the city, it's around about 200 per 100,000 for the over 60s, so it's still kind of relatively lower. So it's not a really steep upturn in cases, but yeah, we are seeing it. It's obviously a vulnerable group that we're concerned about. But to be honest, it's probably a kind of complex mix of issues, and there's ongoing work to try and kind of understand it and predict through as we go kind of where those rates are going to be. But you'll have seen from kind of some of the national work, there's kind of differences in opinion in terms of modelling, because it is extremely complex. Thank you.
Councillor Grimmadell.
Thank you, Chair. I just really wanted to ask who aren't taking the vaccination, which part of the community isn't taking up the vaccination within the city?
Again, it's fairly mixed, but if we look across the city, it's probably kind of lowest uptake rates within kind of the real kind of inner city parts and kind of the more deprived areas of the city.
Do we know why?
Again, it's a fairly mixed and complex picture. I think it kind of varies between different communities and different age groups, so there is kind of mixes of
Alison, you need to address the mic, or it just won't register. People who may be watching just won't hear you. We're all accustomed to just speaking to mics and turning our back on. I'm sure Councillor Grimmadell won't mind.
Well, I'm getting accustomed to meeting in real life. Normally I just stare at the screen, so it's probably quite a novel experience seeing real people and ability to speak to them. So again, a bit like the kind of over 60s case rate, it's a fairly mixed. There's quite a wide range of different reasons. So hesitancy is one, but there's other issues in terms of accessibility and making I suppose making it as accessible to people as we can. So the work that some of the work that I explained there is kind of what we're trying to work alongside communities to understand kind of the different nuances and kind of different and varying reasons why different communities are not uptaking the vaccination or not to the same level, so we can deliver things that kind of will relate and engage those communities to try and kind of increase those uptake rates. And that's been ongoing and continues ongoing.
Councillor Lonsdale?
I'd quite like to know a bit about the pressures that the hospital are facing with the increase. The people who are getting admitted, you say they're not, there's not as many, but how long are they staying in, and is it still affecting day-to-day running of the hospital?
I've probably got colleagues that are kind of much more familiar with that than myself. I think overall, obviously, the rate of admission is much less than it was. There is a piece of work kind of on, I know kind of certainly the kind of Royal Derby are having a look at length of stay and how long people are staying in. But in terms of the conversion, so the number of people that have COVID, the proportion of those that are converting into hospital admissions is significantly less. So obviously the impact is kind of less than it was from COVID, but obviously the well, not just the hospital, but kind of the whole of our kind of health and care system is under quite a bit of pressure, and a lot earlier than would normally be the case. So kind of any activity is obviously impactful. I don't think as many of those people that are being admitted are then having to have kind of intensive support whilst they're there. So kind of the numbers for that are kind of in kind of ICU at kind of over recent weeks have generally been in single figures. So kind of much less impact than it was, but obviously that on top of kind of wider pressure is significant, and is why we're obviously concerned around the continued high rate, particularly as we move into flu season, and the factors that have been around kind of over the previous 2 years in suppressing COVID have also suppressed things like flu and other viruses.
Okay, I'll bring you in a second, Councillor Cooper, because I've just got a slightly connected question with that myself, which is, I don't think you gave us the current number of deaths.
I'll have to look that up and send that to you after. I've not got the figure for that.
Okay, I'm sure the whole committee would be interested in receiving that. Please, Lindsay, thank you.
Yeah, but yeah, my understanding is it's low at the moment, much lower than it was, but I'll pull out the figure for that for you.
Sorry, Councillor Cooper.
Thank you, Chair. I've just got one point, if you don't mind me raising it from what Councillor Grimmerdale asked about demographics, and then I've got a question. Is that okay, Chair?
Yes.
Thank you, Chair. So, following on from what Councillor Grimmerdale asked the question about, which of the demographics that seem more hesitant within the city, has there been any work done, and could you provide it to the committee about particular, say per ward, what is the approximate take-up rate per ward for those that are eligible for the first and second vaccinations? Could you provide that?
Yeah, I can. If I send you the link that was kind of in the presentation, if that'd be helpful. So that, whilst it's not ward level, it's actually kind of just below ward level. So you'll be able to see kind of in those areas, kind of the eligibility and kind of uptake levels. And if it'd be helpful, I can get my colleague to get in touch, as she's got kind of more detail in terms of the work that's being undertaken and the particular issues that communities are having, if you'd like more detail on that.
I think people do want that detail, don't you? So yes, please. And just finally, Councillor Cooper, and then I think that's the last question, unless anybody... Yeah, thanks.
Thank you, Chair. Thank you, Alison. So my question is, in my day-to-day casework that I get through from residents and people raising awareness of issues, one of the issues that was raised quite a few times to me, was about people under 16 having the vaccination, and it seemed to be a bit of a concern for an amount of people. The question is what is the take-up rate? Because I saw on the presentation it was added in with the rest of the general population. What I'm interested to know is what is the actual take-up rate for school-aged children? Would you be able to provide that detail?
We don't have that level of detail at the moment, and it's not reporting through the national system, and so we've not got that figure locally at the moment. And I get in touch with NHS colleagues, they may well have that. But anecdotally, I think we're looking at about sort of 40%. But that is just kind of anecdotally kind of what I've had fed through to me. But I'll see if we can have further, again, I'll see if I can get kind of more detailed figures on that. But I think generally when we're talking about those cohorts, I think the younger age groups, those kind of 12 to 15, it has been generally lower, because I think there's probably kind of a kind of bigger range of issues and concerns that those groups are having. But I don't have the detail.
Well, if you do have any, if you can get some details, and you can forward them to us, thanks, Alison. That would be great. Thank you. And just possibly the last question here on this report, Councillor Hussain. Thank you.
Yeah, sorry, Alison, if you covered it in your presentation and I missed it. What percentage of population in Derby has been vaccinated? The adult population.
So it was, I think, 77% across the city have had the first vaccination, and off the top of my head, I think it was 71% that have had the second vaccination.
And those people who haven't had the vaccination, are we still doing something about trying to reach out to them? Because there's a significant chunk that's missing. I thought it would be somewhere around late 80s, maybe early 90s.
Yeah, and
by now.
Yeah, and it's certainly in some parts of the city it is absolutely that level, but we've got kind of much lower rates with some parts of the city. But yeah, absolutely, there's ongoing work to try and kind of keep chipping away at that. So it is kind of gradually kind of up in, I think over the last, probably in the less than a week actually, it's gone up a few percent. So we keep chipping away at that, alongside also obviously the push of the booster vaccination programme as well. But obviously some of because the kind of younger age groups, and particularly the 12 to 15, is a relatively new to be part of the eligible population. Obviously that's brought so it sounds kind of lower than it perhaps would have done a couple of months ago. And also we've had, as I've mentioned kind of in the presentation, we've had quite a number of outbreaks within schools, and if somebody's kind of had COVID, then they have to wait 28 days before they're eligible or are able to have the vaccination. So that kind of pushes that along a little bit. So, you know, for example, I know my daughter had COVID when she'd got a vaccination booked, so then had to wait a further 28 days following that to be able to get the vaccination. So I think with the coming of those younger age groups and some of those issues around kind of the level of COVID within those age groups, that's also kind of pushed on. But absolutely there's ongoing, the work has kind of been ongoing and will do while we continue to push that, because that is the biggest impact that we can have on it.
Thank you, Alison. This is the absolutely last question, I think, has to be, and only because it's Councillor Grimmadell, am I allowing one more question on this report? Thank you.
Well, thank you, Chair. My question is very, very simple, and I would imagine it'll be a short answer, but I'd like to know, if possible, how long Midland House will be operating for?
I don't have that, so it's a quick answer. I don't know, but again, I'll get that. Absolutely.
Thank you. No further burning questions on this topic, but that has been really interesting. Thank you, Alison. I think there is a lot of desire to know more facts about what's happening at the moment, because we know we're at a critical period really in health and social care in the city, and we're getting towards the really difficult winter months. So I think if we could have that information, and
I'll look to include it in kind of our next report as well, so it's kind of there as routine, if that'd be helpful.
Thank you very much. Thank you. Right, now we move on to the report on the hyperacute element of the stroke service, which I think is coming from Zara Jones, who's the Executive Director of Commissioning Operations at Derby and Derbyshire CCG. Thank you very much, Zara.
Thank you, Chair. Good evening, everyone. And also just to introduce my colleague sat behind me is Joe Keogh, who's a Divisional Director at Chesterfield Royal Hospital. So just between us, we're just going to run you through a few slides just by way of context and introduction before taking any questions. So could I have the next slide, please, Lindsay? Thank you. So just to outline a bit of background, we're really keen to come to the committee this evening just to give some sort of early insights into some very important work that we're embarking on within the Joined Up Care Derbyshire health and care system, and specifically focusing on the hyperacute stroke unit at Chesterfield Royal Hospital in the north of the county. We're really keen to, through this process, obviously take any questions and to sort of follow up on those things, but also just to get your feedback on the level of engagement you'd like in the process going forward as well. So hopefully we'll be able to revisit that sort of towards the end of the session, so we can appraise you on things throughout the process as we go. So just very briefly then, so we have the NHS long-term plan in place, a 10-year plan for the NHS with a range of clinical priorities set out within it, and stroke is absolutely identified as one of those top clinical priorities. As part of that, there are a number of challenges that providers face to deliver all of those clinical priority outcomes, and for Chesterfield Royal, they are certainly not alone in some of the challenges to deliver all of the stroke service outcomes that are required. There are particular issues around workforce, particularly consultant level medical workforce, which Joe will give a little bit more detail on shortly in terms of the challenges faced by the organisation. But we are doing some really important work to look at this part of the stroke pathway, which is described as the hyperacute part, which is effectively the first 72 hours of the pathway for a patient. Saying that, though, we are also doing wider work across the entire pathway, because it's really important that all parts of the pathway for a patient who experiences a stroke, that all of those bits are in place, whether it's the sort of immediate emergency response through the ambulance and emergency departments, through the acute services themselves, but also post-stroke, the early supported discharge and the rehab elements of care as well. So we're doing work across the piece, but this is very much about the hyperacute aspect. If I could have the next slide, thank you. So Chesterfield have been very proactive in the last year or so to ask for independent review of their stroke service, and this links to a number of historical issues, and obviously I've mentioned the workforce issues, but also wanting that independent scrutiny of how the service has been operating and where there might be room for improvement. So the Royal College of Physicians were invited in to do a review, and out from that work came a stroke improvement plan with a range of actions and recommendations around the key areas that you can see on the slide here. So absolutely around the staffing and workload pressures, also around clinical leadership and the presence of that clinical leadership to drive the service delivery on a day-to-day basis, as well as the more strategic aspects, and also the governance mechanisms and by way of sort of reporting the data and how we made sure that we were assured of a high quality, safe service being delivered. It's fair to say that Chesterfield Royal Hospital, in collaboration with other partners across the health and care system, have made significant progress against that action plan, and very pleased to report to the committee that against a sort of plethora of different recommendations, by and large, many of them have been actioned, and the service is in a good position as a result of that. However, what we are left with is the more wicked issues, particularly around recruitment, which are national issues. They're not specific to Chesterfield, but they do leave the service vulnerable, particularly if we were to see any further consultant staff leave the organisation or any particular vacancies within the stroke team. So we've addressed the sort of operational issues and a number of the independent recommendations, but this is where we've sort of ended up now in terms of some of these national issues which are very much impacting on Chesterfield. I suppose the other thing to say before sort of handing over to Jo to go into a little bit more of the detail around the Chesterfield service is obviously we're talking about patient flows across the whole of the county, both within Derbyshire itself, but also flows over the border to other providers. And just by way of context, we've developed a contingency plan should any sort of short-term positions sort of arise, particularly around the consultant workforce that I've set out. And in terms of Derbyshire patients, about 35% of Derbyshire stroke patients have treatment at Chesterfield Royal Hospital, whereas about 57% go to University Hospitals Derby and Burton, with the remainder going to other providers, other acute providers outside of Derbyshire. So clearly the UHDB is a much bigger organisation than Chesterfield Royal. So just by way of context, a significant proportion of patients, Derbyshire patients, go to UHDB, but I say about 35% for Chesterfield. However, if Chesterfield was to encounter those sort of short-term operational pressures, we've developed this contingency plan by way of saying where the activity might go on that short-term basis while we're trying to address the issues. And actually the natural flows for Chesterfield are to the north, so the Royal Hallamshire, from modelling that we've done, would probably look to absorb about 65% of that Chesterfield activity. A much smaller proportion, about 9% for University Hospitals, Derby and Burton. So just to sort of place that in terms of patient flows, clearly those sorts of decisions would be made in conjunction with the ambulance service or services involved and the neighbouring providers. But just so you've got a sense of the scale of some of these pressures that I'm talking about. So I'm now going to hand over to Jo just to go through the next few slides.
Thank you, Zara. Thank you, Chair. So if we could move to the next slide, Lindsay, please. Oh, you've done it already. You're ahead of me. So we talked a little bit about the medical workforce risk. And as Zara clearly articulated, the pressures to Chesterfield and across the entire system are significant. In terms of the stroke consultant, we absolutely really require their level of expertise at the front end of the pathway, hence impact on the hyperacute stroke unit element. The contingency that Zara articulated is reflective of those workforce pressures. If we could move to the next slide, Lindsay, please. Here, and hopefully you can see that this is HASU SNAP indicators. HASU, the hyperacute stroke unit, and SNAP is Sentinel Stroke Audit Programme. That's a healthcare quality improvement programme that measures the quality and organisation of stroke care in England, Wales and Northern Ireland. So there's a plethora of indicators, and what I've shared with you today are the HASU elements. So this is what we're really focusing on in terms of the review. You will note that these are April to June indicators. Obviously, we run some time behind in terms of the outputs, but you will see there probably, maybe surprising to you, but not across stroke organisations, a sea of red. We are doing, better in some elements, some areas that we could improve in. So we had a deterioration in the specialist assessment, so that was down to an E. We've remained stable around the MDT working and around the actual stroke unit admissions, but you will see that variability there, and I thought it was only pertinent to share that with you in terms of the challenges that we continue to experience. If we could go to the next slide, please. So, Zara referenced a task and finish group. So, following the review, Derbyshire Stroke Delivery Group recommended a task and finish group was established to lead the service review and option appraisal of the HASU service. We have secured Deborah Lowe, who's the NHSEI National Clinical Director for Stroke Chair, to lead our independent review. It started in May 2021. We meet monthly to agree actions to drive the programme forward, and that group reports directly into Derbyshire Stroke Delivery Group and subsequently up into planned care element of Joined Up Care Derbyshire. What we started doing was to have a look at a set of future delivery models, and that was sort of looking at the experience of the stroke guru in terms of Deb Lowe, and actually thinking about, you know, what did our population need. It's about service sustainability, it's about service safety. However, Chesterfield aren't the only provider. We work as part of a system. Zara's referenced UHDB, the Hallamshire. We also work with Stepping Hill as well for patients, just on that Derbyshire, Cheshire, Manchester border. So it is quite a broad network. So to support identification of the preferred option and to provide transparency on decision making, an outcome matrix and criteria is being developed. If we could move to the next slide, please. I'll talk a little bit about how we're going to consider the options, but I wanted to share with you the actual options available. So 5 options have been considered. So firstly, that Chesterfield Royal Hospital's HASU provision continues as it is, delivered by the existing substantive consultant and the locum support and telemedicine that we use particularly out of hours and at weekends. Second option is that the current service is strengthened by redesign, and by redesign I mean increasing the number of nurse consultants, acute care practitioners, by increasing therapy support. We introduce a review and convey model, and this is a model where patients are assessed and treated within the accident and emergency department, followed by immediate transfer to a hyperacute stroke unit out of Chesterfield. The fourth option was that we decommission the Chesterfield Royal Hospital HASU element of the service, and patients would go either to a single hyperacute stroke unit or multiple providers. And again, just sort of a list there of the providers, including Sherwood Forest. Just for noting as well, our regional centre for East Midlands is Nottingham, and there is a regional centre at Sheffield too. And the final option was a review of the Chesterfield Royal Hospital HASU service as part of a wider East Midlands review to rationalise sites. East Midlands are slightly behind in terms of that integrated stroke delivery network progress. We've already seen that change happen across South Yorkshire and Bassetlaw. If we can move to the next slide. I thought it'd be really pertinent just to outline the UHDB position as you represent the wards of Derby. And I'd like to thank James Scott, who's the stroke consultant, for providing this position to us. The UHDB position is that consolidation of the HASU element onto the Royal Derby site was the right clinical and strategic option.
Sorry to interrupt. Could you just, sort of, instead of using the initialisms, would you mind using the actual words?
Of course.
Thanks.
On consolidation of the hyperacute stroke unit on the Royal Derby Hospital site was the right clinical and strategic option. However, the combination of greater than anticipated patient numbers and operational issues has stressed the service to a degree that was not envisaged in the original modelling. If we could go to the next slide, thank you. On the Royal Derby Hospital site, the hyperacute stroke unit is the 6th busiest in the country, and it's treating around 1,340 confirmed strokes per annum. There are 11 whole-time equivalent medical consultants required based on the population. There's currently 7 in post. There is, however, a consultant clinical nurse specialist and therapist expansion plan in development. And if Chesterfield Royal Hospital hyperacute stroke unit service were to be decommissioned, the Royal Derby Hospital site would expect an additional 83 patients per annum, including mimics. And mimics are patients who will present with, I suppose, the signs of a stroke but aren't actually confirmed stroke. So, how do we address these issues? If we could move to the next slide, please. On the 25th of November, there is an option appraisal workshop that is a collection of all the key stakeholders, including public stroke survivors, will work together to produce a comprehensive document for review and scrutiny by an independent panel. We think it's really important that there is that independent lens, because the stakeholders that will be present at the workshop and the stakeholders that have been involved in the task and finish group have their own priorities as systems or as providers or as organisations. So post-workshop, a date to be confirmed, we're hoping it will be the 13th of December. We hope that the independent panel would be in a position to make a recommendation to Derbyshire Stroke Delivery Group of a preferred option. So out of those 5 options that are going to be presented, based on the evidence, based on the expertise of the independent panel, a preferred option would be presented. Thank you.
Right, thank you very much for that. Any questions? Councillor Hussain.
Thank you for that presentation. I was wondering whether there is a particular background to this improvement plan, or is there a realization within the organisation that you perhaps are falling behind the rest of the country in your service delivery in certain aspects, so therefore you're trying to improve things because you're trying to catch up? Or have you been inspected and they've told you that you're not delivering a good service and they require you to produce an improvement plan? What is the case?
Okay. We haven't been formally inspected. Zara mentioned that the organisation recognised that in terms of our performance, there were elements that weren't optimum, and we requested that external review by the Royal College of Physicians. So that was at our request, rather than perhaps the Care Quality Commission coming in and saying. If we were to have a look at the national database, you would see that many organisations are in a similar position. University hospitals and Derby and Burton are too. They have a bigger service, so they have more resilience in the consultant body. So at the moment, we only have one consultant that's actually in post. So that makes our service fragile, hence the contingency plans.
Thank you. Councillor Grimmadale.
Thank you, Chair. I was just trying to really work out the Chesterfield Royal. Is the Chesterfield Royal a centre of excellence now for stroke care? Is that what's happening here? I just wondered where the Royal fits in with the stroke treatment. And when we talked about 35% of patients from the Royal go to Chesterfield Royal, is that the case? I just wonder what the criteria was for patients from Derby going to Chesterfield.
Thank you. So in terms of the data, this is more about patient flows than about sort of centres of excellence. So Chesterfield is a district general hospital, a much smaller organisation than by comparison, for example, with university hospitals of Derby and Burton. So the 35% is effectively the activity level of, if you take all of the Derbyshire patients in terms of stroke activity, if you look at the data around that, about 35% of Derbyshire patients go to Chesterfield Royal. So it's not on the basis of outcomes or clinical excellence. It's more sort of operationally about where those patients live or where they're based at the time of their stroke symptoms and where they get conveyed to by ambulance or where they might self-present at a hospital. So it's more just about saying that just over a third of Derbyshire patients are impacted by the challenges that we're presenting. However, going on from that, the patient flows are such that actually if Chesterfield couldn't for a period of time receive those patients, a vast majority would go north to Sheffield, with a smaller number going to Nottinghamshire and a smaller number still going to Derby.
Could I also ask, you mentioned a mimic. Is that similar to a TIA?
To a TIA, trans-ischemic attack. It can present in a similar way. The treatment is different, but there are many conditions where patients may present perhaps with a slurring of speech or a drooping of the face, perhaps some sort of cerebral, some sort of palsy. So I think in terms of, particularly if a patient calls an ambulance, the patients would be treated as a stroke to access the treatment if required.
Thank you, Councillor Cooper.
Thank you, Chair. Thank you, Zoe and Joe, for that presentation. Yeah, some of the information on there, Derby Royal Hospital being the 6th busiest in the country is a concern. I know that strokes can be devastating for some people who suffer them. It must be awful. I can't imagine. My question is more along the lines of before they come to the acute services. Do you guys work really well with preventing people using the service? Is a similar amount of resource put in to try and stop people from coming through the doors of the acute stroke units? For example, I think Diane knows, Councillor Froggatt knows, that I've quit smoking recently. So I'm hoping that in the future reduces, my chance of having a stroke. So everyone's got to try their hardest to make themselves healthier. But what are the resources that are going in to stop people coming through your doors, and how much interaction do you have with those?
Thank you. That's a really good question. And the short answer before expanding on it is we need to do more, and we recognise that. So we are certainly looking at, particularly under some of the legislative changes that are happening within commissioning in terms of healthcare going forward, how we put more of our resource allocation into the more, as we call it, upstream services, so the preventative methodologies, the more sort of self-care side of things as well. So there are obviously a range of factors that can come together to cause an individual to have a stroke, and there are a number of services that we already invest in terms of making sure that we commission the right things that are more around prevention, as you say, as opposed to treatment measures. But we need to go further. The challenges we face, though, generally, and it's not necessarily just around stroke, but stroke is a good example, is that we're just seeing that constant increasing in healthcare demand and need. Therefore, it's that balancing act between the amount of resource that we put into treatment and care at that part of the pathway that we've been talking about this evening, as opposed to the more preventative side. But you've absolutely struck on the right thing in terms of if we do more preventative work, we will see less strokes eventually, and therefore some of these issues that we're facing operationally, actually you'd hope that the resources would be used differently so we wouldn't have such a challenge. But it's a long-term thing to invest in. We won't get quick gains from it.
Okay, thank you. I have a quite a general point, really. I think I can see that it is important. First of all, it's very important that you've got the staff that can actually treat people, and that's clearly the nub of the problem that you've got at the moment. And obviously that will be driving a lot of this. But I think another point, and obviously, in a sense, if your nearest and dearest has had a stroke, you want them, well, not in a sense, absolutely, you want them to have the best treatment. But I think there's another factor to this, which is about recovery, particularly perhaps in where the stroke isn't so severe. I don't really know, or even if it is severe, but is the ability of that connection with the hospital, the ability of relatives to visit. So I'm a little bit concerned that, first of all, as Councillor Cooper said, that the Royal Derby is an extremely busy site. We all know that. We've all been there, and it's an incredibly busy hospital now. The entrance is a bit like, a railway concourse or something at London Victoria. And then obviously the Royal Derby is expressing the pressures on their service already. But I think also from the point of view of Chesterfield as a district, I mean, Chesterfield is a distinct centre, as you know, geographically, and in terms of people's social and sort of people's mental mapping, you see, of where they live. And so I understand from your point of view, you're just seeing this as units here, a county, a flow of patients, but actually these are human beings who have connections with places. And I think that most people up there, particularly north of Chesterfield, relate more to Sheffield than they do to Derby and go to Sheffield more frequently. But I just know that there's an area, Chesterfield itself is a fairly deprived town, and I know many of the villages around it, like New Whittington and other places, are they're not all the wealthiest of villages. People don't always have cars. They don't, and there's not always a huge amount of mobility there. There's a lot of, it's an aging population because all the young people are moving out of northeast Derbyshire. So that whole picture to me leads me to think of the 70-year-old woman in New Whittington, say, whose husband's had a stroke. He's whisked off to Derby. She's probably been to Chesterfield a few times. She rarely goes to Sheffield. She's possibly never been to Derby. And this won't be uncommon in the population of the North Derbyshire. The bus fares, all this presents a problem, and she's not young herself. So I suppose, what is your sort of reaction to that? And also, that also feeds into this idea of the viability and the importance of Chesterfield as a hospital. If we keep reducing its, the services it delivers, would that threaten the hospital in the long term? So a rather long point, but it's a comment more than anything. Thanks.
Thank you. It's really important comments on a number of areas. So I suppose just the first point, absolutely, we're talking about numbers and data, but there's a person behind each of those. So just to make that clear, and we're very patient-centred in terms of this. And linked to that, I think it's really important that we're doing a process here which looks at a range of criteria, which isn't even just about that one patient. It's also about, as you say, the family connections, the caring responsibilities, the travel, the accessibility. So I suppose there's an assurance point in what I'm saying that we're going to be looking at all of those factors, and the point of having this wide stakeholder workshop in a couple of weeks' time is to make sure we hear all of the views from all the different perspectives. However, saying that as well, though, we have, I suppose, a duty of care also to our population in terms of clinical outcomes and making sure we have safe services. But it's our role to balance all of those things. So the medical workforce challenges are very stark and very real, and I think we've done a good job locally to put this contingency planning in place to help to make sure that we know what we would do if there were particular issues that were to arise. But unfortunately, that doesn't address the longer term sustainability, which is why we're doing this process. So sorry, that's sort of a long answer to probably what should be a bit more succinct, that says that we are looking at all of the different criteria, and all of the points you raise are absolutely part of that process. And then the independent panel, I suppose, have the difficult role of weighing up all of those things and saying, from that, what are our recommended options? And we'd obviously want to keep talking to you about that as the process unfolds.
Okay, thank you very much. Any more comments, questions? So I think thank you very much for coming. I think you've heard our points, and I think if you could take those away with us, and we'll just note the report and thank you for coming, and we look forward to receiving an update on how this is progressing. Thank you very much. Now we are going to hear from Liz Swain, who is the Assistant Director of Integrated Community Commissioning at Derby and Derbyshire CCG, and following a report earlier in the year at our first meeting on the London Road Community Hospital rehabilitation wards, we asked Liz to come back and to give us some evidence that permanently closing those wards and having no rehabilitation beds in Derby is a viable way of discharging people from hospital and delivering the service in the future. So, Liz, thank you.
There we go. Thank you. So thanks for inviting me back. And I'm here tonight to give you an update. It's probably not the full report back because we've realised that actually that's going to take us a little bit longer to provide you with a really robust analysis. But I'm going to show you how far we've got, the methodology that we are using, and also our next steps, and show you through the process that we are going to be. We'll be happy to come back again if you're happy to receive us back with the full report. So I was here last time, I think it was in June when I came back, when I was here with Mike, and we took you through the London Road, Florence Nightingale Community Hospital, wards 4, 5 and 6 progress. And we suggested that we would start an engagement process around October time. As we realised when we spoke with you last time, that we weren't quite ready for that launch because of the outcome data and the analysis that we still needed to provide and to work towards. So the launch of the engagement hasn't happened, and we are looking to potentially start probably in the new year after we've pulled together the robust report that I will take you through in terms of what we're going to show. So just to remind you, the Florence Nightingale Community Hospital, otherwise known as London Road Community Hospital, wards 4, 5 and 6, we're offering short-term rehabilitation beds, have been temporarily repurposed to support the COVID-19 response, and that's what we explained last time we came. As a consequence, the system has temporarily used the monies freed up from wards 4, 5 and 6 to pilot a range of improved pathways and enhanced services. And you can see the list on the screen there. So that's dementia palliative care, additional pathway 2A and 2B capacity. So just to remind you, that's rehab bedded facilities. So the 2A are residential beds and the 2B are nursing beds. So we've added some capacity there. There is also a pilot.
Sorry, could I just pause you there?
Yep.
Is that all right? Sorry, it's a point of clarification, so I can follow this quite closely, and I want everybody else can probably follow it. So, when we spoke before, the proposal was that there were to be no rehabilitation beds in Derby. And that it was all going to go over to the Home First system.
Yep.
Are you saying here that this is a specific scheme you want to implement now, which does provide 10 beds, but they'll be in nursing homes? Is that correct?
So that if you remember, we explained that. You are absolutely right that there are at the moment no additional beds in the city, but that we were exploring and were able to, if we needed to, commission 10 beds in the city. and the position that we're in now, we are at the moment, we will be block purchasing some beds, 10 beds in the city, but we haven't yet done that. So the reason behind it is that we have been keeping a real eye on the capacity and the demand within the area. So I hope that answers your question.
So just the chart we have here is what the, I know it says improvement ambition, but this is literally that. You haven't actually done this yet, it's what you're hoping to do.
Yes,
okay,
right.
Sorry for the having to ask for that clarification, but that's very useful, thank you.
Okay, thank you. So then the other elements of the pilot range of services that we've been actually delivering, and yeah, apologies, that's not that clear from the table. In the city is the enhanced P1 service, which is known as the Delirium Pathway. So again, that's additional capacity. We've also had additional capacity in the Discharge assessment unit, which is delivered through UHDB, and also the Frailty Admission Avoidance service, again at UHDB, which ultimately supports the flow of patients, either preventing them from needing to be admitted into the hospital through the admission avoidance frailty service, or in fact when somebody has had a stay in hospital to be helped to discharge to the right place through the Discharge assessment unit. And then finally the sixth element is some monies were added to capacity for DCHS to provide and support again the P1, P2 offer through the home.
Okay, I think that's with our previous speakers, and I did mention this last time. Can you please explain the initialisms and also P1, P2?
I'm sorry. Yes. So P1, so Pathway 1 are rehabilitation services for people when they're discharged back home. So it's care in a person's home along with rehabilitation. So that's occupational health, occupational therapy and physiotherapy in a person's home. That's the Pathway 1. And the Pathway 2, again, is linked to residential rehabilitation beds that we have in Perth House in the city.
Okay, and can you just confirm what is DCHS?
And DCHS is our main community provider for Derby and Derbyshire.
So what does that stand for? What does it mean?
Derbyshire Health. Where are we? Derbyshire Community Health Services.
Okay.
Okay, if we could move on to the next slide, please. So again, another question when we were here last time, you were concerned about the governance arrangements for the process. So the big chart there, you can see lots of boxes, and both city and county scrutiny committees are at the top there. We have Joined Up Care Derbyshire Board, the CCG governing body, Clinical Commissioning Group governing body, and in the middle there we have the Integrated Community Place Board. So all the changes that we have been talking about and been discussing have been progressed through the LRCH, which is London Road Community Hospital Programme Board, and has been reported into the Integrated Place Board, and then to the Joined Up Care Derbyshire Board, that's the JUCD Board, and then of course we come back here to the City Scrutiny Committee and also to the County Scrutiny Committee. You'll also see along the bottom All the different work streams that I kind of just outlined, again, they have smaller working groups, and again, they feed back into the programme board. We also report into the Derby City Place Alliance and the Strategic Discharge Group, which is a group which oversees the discharge to assess process. So the pathways that I talk about, so the P1, P2A, P2B, Pathway 1, Pathway 2, Pathway 3 that I've spoken about, that is discussed and overseen at the Strategic Discharge Group. So hopefully that gives you a flavour of the governance arrangements that link to the Florence Nightingale Community Hospital programme. If you could go on to the next slide, please, Lindsay. So this slide just gives you a flavour, again, of the Communications and Engagements Plan. And I think this is something that we shared with you last time. I think last time we were very eager to begin the engagement programme, and we came to discuss with you and for you to give us a steer in terms of what your thoughts were of how we could improve our engagement plan. So we have listened to you, and we are still developing that plan, but we have now been through a process of quality and equality impact assessment, which has looked at all those programmes that I've just described and the overall programme of change that we are suggesting for Florence Nightingale Community Hospital wards 4, 5 and 6. So like I said, the engagement plan is still being developed, and we are probably going to be launching it in the new year, but not before. Thank you, Lindsay. So the main question you asked last time was around the evaluation, the metrics and evidence, and how can we show that. Next slide, please. Thank you. So we have developed an evaluation framework which looks at 4 main aims. First one, to improve outcomes in population health and healthcare. Second one, how can we tackle inequalities in outcomes, experience and access? How can we enhance productivity and value for money? And how can we help the NHS support broader social and economic development? So they're the 4 key aims that we are looking at in relation to those work streams. And we're in the process of evaluating those pilots against those 4 aims. In terms of the next steps, you can see there's a date that we had a workshop where we agreed the methodology, and that was, I think, alongside when we were meant to be meeting with you. I think it was a similar date or just after, but that obviously has now happened, and we have agreed the framework, and we're in the process now of pulling together the evidence that each of the work streams have been collecting and collating. And I think tomorrow is the deadline for all of the work streams to send in their evidence. Next slide, please. So this slide is, I suppose, an example, give you a flavour of the dashboard as well that we've been developing and starting to use in terms of trying to really understand the data. So again, we've really gone to town in trying to have a very robust, evidence-based way of explaining really and backing up the programme that we are putting forward in the evaluation, in the engagement programme. And you can see kind of towards the end, thankfully we have got some green boxes. So basically what this is tracking are the percentage of people that have been discharged to match their needs for an appropriate discharge, and you can see that in November. Sorry, I've not got my specs on, so I think it's November. Starting August 19, September 19, December 19, and then January 20. And as we go through closer to now, and again, this slide I think was put together for when we were last meeting, so we've got more data now. But it is just showing a pattern that we are getting so much better at discharging people into the right places at the right time. Next slide, please. So again, this was a slide deck that we showed last time. We have updated this one. Again, it's showing the same picture that as we showed before, more people are utilising the pathway 2B. So that's the rehabilitation nursing beds that the Derbyshire Community Hospital services are providing. So whilst they're not in the Derby City, which is clearly what you flagged just earlier on, what it is showing is that there is a greater number of beds available for city patients. Next slide, please. And again, I think this is a very similar slide to what we showed you before, but again, we've updated it since we last showed it to you. So again, whilst the number of people increased going to the nursing beds, fewer overall were actually going to the London Road beds, you know, when you compare when London Road was open. And sorry, next slide, Lindsay, thank you. So what that actually shows you then, culminating with more people going home, more people going into a specialist rehabilitation residential bed, and fewer people accessing the nursing beds, so resulting in kind of better outcomes for patients. So again, that's
again, I'm going to have to interrupt there for a point of clarification. I hope the other councillors will bear with me. I mean, just so it is, it's a shame we didn't have this report prior to the meeting, because I'm sure most people are not assimilating all of this information straight away. But the problem I see in what you've just said is that it's a bit tautological. Essentially, you are setting out to not require the rehabilitation beds in hospital, or they've been closed temporarily anyway, and you are saying, I mean, the question we asked you was because you told us there was clinical evidence that people improve more quickly, recover more quickly if they're discharged to home. But I suppose that's what we were looking for, whereas here what you're presenting is evidence of the success of your scheme by the fact that more people are being discharged to home. So in a sense, that's just evidence that your plans are working. You've closed the London Road Hospital, you're discharging more people to home, and some to the many to the care homes, I understand, at the moment. And so this is just evidence of what you're actually doing, rather than clinical evidence that it's effective, if you see what I mean. Thanks.
I do take your point, and it does give that impression. I think there is a lot more data behind these tables that we'd be happy to share with you. And when we came last time in June, I think we shared with you then some of the audits that we did previously when London Road was open, when the wards 4, 5 and 6 were open. And the audit showed that over 50% of patients who were accessing London Road didn't need to be there. They didn't need to be in a bed, and they would have been better to go to be discharged home. At that time, there was less of capacity. There was the Home First programme wasn't quite as developed as it is now, and what the temporary closure of the wards 4, 5 and 6 has allowed us to do is to develop that Home First programme much more. So that is also what's happening here. But I do understand
Okay, well, I think I'm going to note and confirm then that we're not seeing, what we're seeing is evidence of what you're doing rather than any, we're not, I don't think we're seeing clinical evidence that it's more effective. But I will come back to you in a little while. I'm sorry to keep interrupting you, but it's just really important that we get some of this clarified as we go along. I will come back to you on the Home First scheme, but when you finish, thank you very much.
Thank you. And in terms of the report, I think we did send it through before for you to have a look. But so I'll make sure in future that you do actually get the report well before, so you can actually read through, because there's always a lot of data for you to read. We'll make sure that happens. Okay, thank you, Lindsay. To the next slide. And the next one. So the next, I think there's about 5 or so slides. I'm not suggesting that to go through them all because they are quite focused, but it just gives you a flavour of the alternatives so this one is the Delirium Pathway. So that's providing support to people in their own homes who have delirium. So instead of them having to remain in a bed, they can actually be discharged from hospital back home, where they can recover more quickly, more effectively, with support through the Home First enhanced provision. So that whenever you see the P1 in relation to Derby City, it's actually referring to the Home First provision. Next slide, Lindsay. So like I say, these the next number of slides, I was hoping that you would have had chance to read through. They're not really for you to view now, because there's so much. They're quite dense in terms of the information that's on them. But basically, it's kind of giving you an update in relation to the different services. And when we wrote this, we were struggling with recruitment to the provision, and we are. It is slow, but we are recruiting steadily. Is increasing to that service. Next slide, please, Lindsay. So this one is in relation to the Dementia Palliative Care Team. So this again is provision to support either people at home, in their own home, or in a care home. And the service offers support to carers, so that's unpaid carers, so family carers, as well as care home paid carers. And they've had a lot of success in supporting people. So in the one case, on the one hand rather, supporting people to remain in their own homes, and to have their pain, their confusion supported through specialist staff in people's own homes, and also to help people to be discharged more quickly and effectively back home. So in the one instance, preventing people from having to go into hospital in the first place, but also supporting people to be discharged more quickly back home when they have had to stay in hospital. This service has been in demand, so much so that we have extended the staffing programme, the staffing range, and we are recruiting to more staff for this service because it has proved so effective. Next one, please. So you can see here we have actually exceeded the target number of referrals. In fact, we doubled the target. And we, like I said, we are in the process of recruiting. And we are not having difficulty in recruiting either to this service. It's also been recognised by NHSEI as a really effective, good practice service and has received some external funding as well from NHSEI because of it. So we'll be able to reinvest that into the service as well in terms of the recruitment. Next slide, please. And this was linked to the additional capacity and the 10 beds. And as I said, we're in the process of commissioning some 10 extra beds in the city in nursing provision. Next slide, please. And then this is the...
I think really, you know, this slide is too dense, really. If I could ask you to kind of, you know, I just don't think we're going to get anything from this in this format, really. If you could just give a very quick summary of it, thanks. Or
so again, the uplift in the pathway one, so supporting people at home and supporting people in Perth House. Again, it's about increasing capacity in the therapy service that the Derbyshire Community Health Services provide. And in a nutshell, that's what this slide talks about. Next slide, please. And this just mentions the Derby City urgent community response. And again, this is a provision that links to Home First and the Derbyshire Community Health Services rapid response provision. Again, extra investment into those services which are helping and supporting in the programme that we've just talked about. So these are our additional capacity. And the final slide, please, Lindsay. Is there another one after this one? Yep. Thank you. So the glossary that just flashed up, again, I think that was a request last time. We used a lot of acronyms, and hopefully that glossary will help you when you are hopefully looking back at the slide deck. There's a lot there, but the glossary is there for your use. So this, again, very dense. The last few slides just give you the overall methodology that we're using for the evaluation. So to just, if you could just flash to the next screen, please. Next slide, thank you. And again, it is an appendices, but I'm just kind of flagging this for your information. This links back to those 4 key aims, and what we're going to be doing is using this appendices, this analysis toolkit to assess whether or not those work streams, the alternative work streams, are actually delivering to the 4 aims. And we have an independent, some independent lay members that will be helping us to evaluate those work streams. And it's that we will bring then back again to you to show the analysis of those delivery alternatives, those work streams. Sorry, that's it. Sorry, it's very long. But I wanted to just give you a flavour of the work that we have done.
right, well, thank you very much. I do appreciate that you have responded to some of the points we made, and you come back this evening, and obviously it would have been better if we had access to this before the meeting, because it is very dense, but I appreciate that it's quite complex and that you are working on this, and it's a work in progress, and at the moment you don't have the clinical or the feedback all the responses evidence to suggest that the plan is working or not, as we requested. So thank you. I do recognise that, and I do recognise that that work is ongoing, and I'm sure that the meeting, the committee, the board will want to hear more of that. So, but I am going to take my privilege as chair as coming straight away with a point, if that's all right, because I am regularly briefed as chair and also as a shadow cabinet member for adults and health on the situation in Derby. And I understand that you're engaging with a whole series of complex initiatives in order to bring about this policy. The problem I see, and in broad terms from the briefings I've had, is that essentially Derby is in a healthcare crisis at the moment. Health and social care is at level 4, and that is one reason for that is because they cannot recruit to the Home First service. So it isn't delivering properly, and people are not being discharged from beds, and as quickly as they should be from the Royal Derby, which is causing a whole series of problems. And also more people are being discharged to care homes than would be ideal. And that also leads to other issues, which is basically that is not achieving what you have said to us is the best of their own home, in their own home. Also potentially increases cost on the council because they may end up staying there, in that home for longer. Not that that's a prime consideration, but obviously it is a consideration. So if the committee will bear with me, I think that's my concern, is that from what I have been told, that this just isn't working.
I think we are in a very difficult position going into November and going into winter in terms of recruitment of staff right across the board, and clearly there are the services that we have available are not meeting demand in across the board. We are trying to mitigate and to look for alternative ways of finding provision for patients to be discharged, and one of those is looking to commission some further interim block purchased beds to support people, so that we can try and support flow across the discharge to assess pathways. But you're quite right, we are in the system is under intensive pressure right across the board.
Okay, thank you. Sorry, thank you for everybody for bearing with my constant comments and interventions. Does anybody else want to make a point? Councillor Froggatt.
Yeah, thank you for your report. The chair's actually took mine, because that's what I was going to raise as well. But also on top of these pressures, as we're all aware in this room, I believe it's Thursday when it's basically put up or shut up. If the care workers haven't had their vaccinations, then they are removed from their positions. How is this going to affect what pressures you've already got? Is it, and we know it's going to make more pressures, but how are you going to get around this? Because although you can't recruit, we are going to have even less employees to look after the elderly and all that. So it's like a catch-22. What are we going to do?
You're absolutely right. On the 11th of November, then care staff have to have had be fully vaccinated. So we have been preparing for this time, and I am being told that we have it in hand in terms of the the capacity and in our care, in our Perth house, in our city council facilities, but in our private sector, obviously that is a different matter, because they're independent organisations, they're independent care homes, and obviously they are very concerned as well in relation to the date of the 11th.
Thank you. Yeah, Councillor Foggett.
It's okay saying that we have Perth House, blah, 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 and the other ones are private care homes. They still take for us, for the council. The council still direct patients to these private care homes. So, you know, it doesn't matter whether Perth House is okay. There's only room for so many. So something has got to be done, really. What I don't know, because, like I say, it's a catch-22. It's a nightmare. Unless we actually up the payments to people and say, look, recruit you, we'll give you above the minimum wage. And that's the only way you're going to attract people to these positions. You can't expect people to do what they do. And it is a hard job to care for somebody, whether it's in social care, in the home, or going out to do it in the community. It is hard work. And people are just not paid enough for what they do. And you can understand why people don't take the jobs.
No, absolutely. I mean, it's very difficult, and in terms of what we're trying, we're working together as across the system, both health, social care, and the independent sector. So we are trying our best to do to make sure that we have enough capacity. I do know that we've had some really strong conversations with the PVI sector, particularly in the city and in the county as well, and we've had some really positive conversations, and it is looking like we will be able to block purchase some beds, which will help with the flow and help with capacity. And one of the requirements is that all care staff within the provision are fully vaccinated. So whilst it's very, very pressured, you're absolutely right, it's very, very pressured. We are working very hard to try and resolve and trying to make sure we have the right capacity.
Thank you. Just before I bring in Councillor Hussain, I do actually have I asked for this last week. I do actually have the rates of pay for the council's Home First staff, Diane. It's worth noting that it's above the minimum wage. It's an hourly rate of £10.41, increasing with service incrementally to £10.83. And they do work on a shift basis, which is usually better than the per hour pay. They do get paid for the travel time and mileage payments, etc. So the basic salary is usually between £20,092 and £20,903 a year. And the reason I raise that is that that is better than some of the private care providers, but nevertheless the council cannot recruit and just doesn't have enough staff. Thank you. Sorry about that, Councillor Hussain.
I actually support what you're trying to do. I support the idea of us providing rehabilitation to people who ultimately are going to live in their own homes. And it's a much better option compared to somebody receiving rehabilitation either in hospital or in a care home and then going home, because the rehabilitation package can be tailored more precisely, because you can see people receiving assistance, and wherever there are weaknesses, you can address them as you see people struggle with various things, and you can see them perform certain tasks with relative ease, if you like. But the problem always has been with this sector, because I did manage a discharge team in hospital for about 13 years, based at the DRI. It was lack of appropriate staff being available. That's always been a bottleneck situation. It's not new. It's been there for donkey's years. And when I manage the discharge team, in hospital settings, a consultant will do a ward round and say, yes, this person is not medically fit, and you can begin to get on with making discharge arrangements and get them home. So first of all, we've got to do a comprehensive assessment to see what they would need at home. And then it's a case of finding appropriate bodies, either in-house or from independent sector, who could actually provide that help and support when they are at home. In many cases, somebody who's had a stroke and needs rehabilitation input for 2 or 3 months before they get back to normal, they would probably need 3 or 4 double-ups. That's 2 staff going in 3 or 4 times a day, and maybe some people need a bit of support at night as well. It's practically getting that package together and getting an organization which says, yes, I think I've got staff to provide all that service that you're trying to commission. And increasingly, from what I can gather, although I retired about 7 years ago, the care sector is coming under more and more pressure. So in order for your program to work, first of all, could you give me some numbers that you have in mind in terms of how many people you think you can manage in their own homes and provide intensive input to them over a month or 6 weeks? And then what would be your plan to make your handover to somebody who's going to take over from you? Because once you've done your rehabilitation, you've done, this is as good as they're going to get in terms of improvement. And then they will still have ongoing needs, which they may have for anything up to 3 years, 4 years, for the remainder of their life. Have you thought it through to say, well, this is how it's going to work. You've got 200 staff. We're going to be able to discharge around about, say, 60 patients a month. And then looking at capacity in the private sector to take over from you when you've done your rehabilitation program. What sort of capacity do you have, or do you envisage to have, in order to get more people in their own homes to receive rehabilitation input?
Now, I'm not going to give you a figure because I might be wrong, and I don't know what it is off the top of my head, I'm afraid. But what we have done is we've kind of modelled, we've looked at the demand over a period of time to see what number of starts that we would need, both from a short-term home first type delivery, and also then who then takes over that care, usually in the PVI sector, and how many of those we would need. And so we do have a figure, but I don't claim, I'm afraid, to just have it off the top of my head, and so I'm not going to guess because I'll probably get it wrong. But we have modelled and looked at that, and the investment that we were putting into the Home First service equated to what we'd forecasted. The problem is, as you've so eloquently kind of articulated, is recruiting to that level is very, very problematic and very very difficult. I think the Home First service have a better track record perhaps than the PVI sector, but even Home First now have been finding it more difficult to recruit. So I know that's not a very full answer, but it's an honest one. but I can come back with that data when we come back again with a full report.
That's fair enough. Sorry, Chair, I forgot to mention. Do you now acknowledge that not everybody is going to be in a position to receive rehabilitation in their own home, that you will need some nursing and residential beds? Because if somebody's had a very intense or dense stroke and they're virtually unable to do anything, there is no way you can take them unless you're prepared to fund a package of care at home, which costs you something like £6,000–7,000 a week. A lot of people were put in the nursing homes to receive further rehabilitation, or they were left in hospital because the cost of the package at home would run into £5,000–6,000–7,000, which is a tremendous cost. And there is no way local authority is going to be able to pick up from you the cost when you've pulled out your staff and take over where that amount of funding is going to be required to keep them safe at home.
And yes, you're absolutely right. There are different levels of need. Of everybody has a different level, and so in terms of that, looking across at what the capacity should be, we have modelled that as well in terms of different levels of complexity of need, and that has been factored into the range of provision and services that we are testing out really now. At this moment, and that the report that when we bring back will be really clear in terms of what that is and what that shows.
You, Councillor Cooper.
Thank you, Chair. I think in the last 2 years, I don't think we could have any be more aware of how important our health is. It's been a crazy few years, and I think we've all seen the impacts on communities about healthcare provision. We're going to talk on later about access to GP surgeries, just the day-to-day stuff that people need. By the grace of God, I'm okay. You know, I'm fairly healthy. I'm doing everything I can possibly to get healthier as well for the long-term future. You know, in the presentation, you put forward there about what happened during COVID when patients were removed from not just our hospitals but around the country, and I remember it really well. I don't think I'll ever forget it. Another part of the presentation discussed about the value for money aspect of it, and the question I've got is, I've got two questions really. So, are the 10 beds envisaged for Perth House? And I believe that's a Derby City Council run establishment, if I recall. And then the second, because I may be wrong, I may have not been keeping up as well as on that. The second one is there a cost analysis between the cost for these care home beds and how much those similar beds would cost in Ward 4, 5 or 6? Has that analysis been done, and do you have that data? Thank you, Liz.
So to answer your value for money and the cost question, so that is absolutely why we've got it in the analysis, and that's what we will be feeding back in the report when we've finally pulled all the information together, and we do want to compare it with London Road, because then that makes sense, I think. And that's the other thing, that, you know, in terms of how we present the information, again, these slides are very dense. They're not really 4 slides. They're more as a report really for you to read through. But in terms of when we do come back, we do want to make sure that it's clear for people to see the difference. So absolutely, I think that's a really good idea, that comparison. So and that's our intention. Just in terms of Perth House, so Perth House is what we call a Pathway 2A bed. So it's a residential bed, whereas London Road provided nursing, was a nursing rehabilitation bed. So that's the difference, and I'm just it is confusing when we use all these acronyms. And Perth House has 24 beds. That's the number that Perth House has to offer.
Sorry, Ellen. I think
Councillor Cooper, just want to come back quickly, then Councillor Grimmadale, and then I guess...
I think I beat you by literally seconds. I put my hand up. So, so where would the 10 beds come from? Have you guys got a place in mind? And just approximately, how much would those 10 beds cost?
So the 10 beds, and again, it isn't very clear, so apologies for that, but those 10 beds are nursing beds we are looking to commission to block purchase, so from a facility in the city. So some of the homes that we've been talking to, Landale Heights, Queensferry Court, and Landsmere is the other facility that we have been looking at. I think it's something that perhaps I can't share in this meeting, but I'd be happy to share with you outside the meeting.
I think that's a critical point, actually, please. I don't think that's something you could share privately with one councillor. I think that's a really important point.
Right. I will.
Either you can't share it, you
Yeah.
can't tell us, or you share it with all of us.
Okay. I would be uncomfortable sharing this.
Fair enough, that's understood. Councillor Grimmadale, thank you.
Thank you, Chair. That couldn't be on a pink paper, could it?
It's not been presented at all, so
Okay.
yeah.
My
But yes, we could ask for it to come back as a pink paper. Thank you, that's a good point.
And my question, Chair, is that next time we have a presentation, I would like to see the slides way in advance. I mean, I'm not Councillor Clark Kent. I haven't got bionic eyesight, and it really would help. Thank you, Chair.
No, absolutely. It's what I would anticipate, really. But yes, we've made it clear we'd like the reports in advance. Thank you, and that's been recognised by Liz, hasn't it? Thank you, Liz. Any other points on this? No, I would like to make a recommendation at this stage. I understand that we need to hear further evidence, but I think we're in a scenario where the system is in crisis, where it's not working. We don't have the Home First staff to deliver this care. The care packages to deliver the care for some people, admittedly not all people, but as we mentioned last time, there are people who don't have the family support, they have particular conditions. It's going to cost so much, as Councillor Hussain said, that you do think, well, is this good value for money? Is it worth it overall? Because it might probably be cheaper to have it in a hospital bed, where there's also lots of other support on hand. And the other point is that we are now acknowledging that we need nursing beds, and instead of providing that within the NHS, we're going to care homes and private providers, which I'm not against that totally. I don't think that's something we'd completely rule out. But what I feel that to close all rehabilitation beds at London Road or Florence Nightingale is premature. And I think there will always be a need, as you have quoted in the first report, it said 80% of patients are better in the home. Recently, tonight, you quoted a figure of 50%. So you, in your own stats, you're sort of acknowledging that there's anything between 20 to 50%, but certainly 20% of people who need help, support that involves nursing care. So I appreciate that you are saying you will come back to us, and I know we've taken loads of your time. I think this is so important. And I'm thankful for the councillors for bearing with this. I know it's 7:45. But what I feel is I would like the board to sort of support a feedback comment to you at this stage like this. And I'm saying it to see if the board agree, the councillors agree, to say that the decision to permanently close all the rehabilitation beds at London Road Community Hospital or Florence Nightingale Community Hospital, Florence Nightingale Community Hospital is premature, and it should be reviewed to provide beds within the NHS for those who do need it. So, do we all agree with that? Thank you. So, so do you want me to state that again, Lindsay, or do you have it? Yeah, you got it. Thank you. So, Liz, I know you've given us a really brilliant report. You've tried to respond to what we were asked you, and thank you for coming here tonight. We will hear from you again if that's okay with some of the results of your engagement and evaluation. But I think the message from this board is that we are not convinced that we do not need some rehabilitation beds in London Road. Thank you.
Thank you.
I'm going to move on now, Councillor Cooper, if that's right, because it's 10 to 8 and we are half an hour behind time, but that is a really critical issue for the city, and I think we needed to dwell on it. Okay, we've just agreed a recommendation. You want to make a further recommendation? I do apologise, Councillor Cooper. I've had this problem. I've not been good with you on your recommendations before, have I? Sorry, I didn't know you were going to come up with an extra recommendation. Please go ahead.
Yeah, I think all of us recognise how important this all is, and I'm not suggesting for one moment all eggs are going in one basket, but from what I've heard on both occasions, it does sound like all eggs are going in one basket. I've always gone in the figure, the mind of pretty much everything I do. That if you do that, you do run a massive risk. And the recommendation I'd like to present to the committee is that Liz and her team look into what could a mixed offer be as well. So it's not just having closing 4, 5 and 6 down, it's how it would be mixed. And I know what I'm trying to say is that something else that we can discuss and ask them to look into and look at a cost-based analysis on that, where you've got a mix where you're thinking about using the care homes if required, but also retaining that NHS ward, maybe 1, maybe 2, whatever that looks like. Well, maybe instead of all eggs in one basket, a mixed approach. Consider.
Well, I think I think that's a really excellent point, Councillor Cooper. And I'd suggest that in terms of a formal recommendation, what we've already agreed allows that, because we haven't said that we want all the beds to remain open. We've just said it was a very simple statement about some being kept for those who need it. I suppose you're adding another point. But I wonder if we need to make that as a recommendation, or whether you could just take that, Liz, as if it's minuted, that Councillor Cooper would like more feedback on what the mixed model would look like. Is that all right, Councillor Cooper?
That's fine. Yeah, that's fine. Thank you.
To save time, so that we don't have to spend 5 minutes articulating that in a statement. That so is everybody happy with that? Yeah. Thank you very much then. Right, thank you, Liz. Right, we'll move on then very quickly, because it's our last report and we are half an hour behind time now, with Clive Newman. You're going to get... Okay, we're going to adjourn the meeting for a moment while Clive Newman enters the room. Right, thank you very much. We now have a report from Clive Newman, who is the Director of GP Development for Derby and Derbyshire Clinical Commissioning Group. I'd like to apologise to Clive for the fact that we had to wait a little while, but we did have a really important issue dealing with just then. So you're going to present the report, which we have received in advance, on GP appointments face-to-face and online. Thank you.
Thank you very much, Chair. Could everybody hear me? Yes. Yes, thank you, and thank you for inviting me to attend. I hope you've had a chance to see this. I know we're running slightly late, and so I won't go through every slide in detail. And actually, since we produced this, there's, as you may know, there's been another government policy been issued that we'll probably need to bring into play as well. I'll just provide you with just run through these slides quickly. They provide some background information, really. So just to give you a sense of overall general practice activity, in the county, the city and the county, we offer about 500,000 appointments a month. It's by far the biggest provider of health service appointments. Obviously, it's changed since the pandemic, and a lot, I think, of this conversation has been driven both here and nationally by those changes. One of the big changes, although the number of appointments offered is broadly similar, if not slightly more than before the pandemic, one of the big changes is that the number of face-to-face appointments has fallen. So the number of appointments face-to-face at the moment are running at about 60%, number of telephone appointments at about 35%. And I think before the pandemic, nationally and in Derby, that was more like 85% for face-to-face appointments. What has slightly improved is that the number of overall appointments offered on the same day has increased. So effectively, you're likely to be spoken to by somebody on the telephone on the day you ring. Overall, our activity, our performance is about on line with other counties in the Midlands, and in fact with the third best county in the Midlands for the overall number of appointments offered. And we are seeing at the moment a significant increase in demand, with appointments currently surging at about 10-12% than we would normally expect to see at this time of year. Thank you. Next slide. Yeah. I won't go through these slides. You've got them in the pack. It just gives you an indication of the overall number of appointments compared over the last 4 months, well, 4 months to this point, compared to the 2 years previously. Next slide, please. And that, again, you've got this in your deck, and it's not a great slide to be able to talk through. So I won't talk about that in any great detail. Next slide, please. This slide highlights, apologies, this is slightly out of date information. Obviously, it was done for the last meeting, and then that was rearranged. Overall, just to give you an updated, some updated figures, we are now about from the September data, we're at 7.2% higher in terms of appointments than the same month 2 years ago before the pandemic. Same day appointments has gone up 19.5%. And the number of appointments offered overall has risen week by 50% since the end of August. So from the end of August to the end of September, we've actually increased the number of overall appointments in any given week by 50,000 across the county, but that figures also will be the same in the city. Next slide, please. As you can see, this is my point really. Effectively, you can't really tell we're the yellow line in the middle of all of the other lines on the right-hand side, but we are, you can see actually it's remarkably similar across the country and across the region in terms of the overall number of appointments offered and what those appointments look like. Next slide, please. I've run through this. Yes, effectively fallen from about 80% to 50%. What I'd like to say, though, to start, is that this has been national policy for a long time. The strategy issued by the Department of Health in 2016 talked about a digital-first appointment programme. And the idea behind that, really, that's driven by the fact that actually often, just like with everything, different appointment modalities offer people more choice, and it gives you more opportunity to see the right person first time. So fundamentally, the strategy is you should be triaged, and then you should be shown to the right door, to the right person, face-to-face if you need to, but also over the telephone or even online. So this has been part of a national strategy for a long time, obviously escalated significantly by COVID. All practices now in Derby are open. They have been open now for months. They're offering face-to-face. They, in fact, the vast majority of practices have been open all the way through. Some branch surgery is closed because of IPC, infection prevention control constraints, or simply because of ability to staff, but they are all back open and running. Next slide, please. Yes, overall, the issue about face-to-face has become face-to-face is good, everything else is bad, and I think that is too binary. Obviously, if you need to be seen face-to-face, you should be. There is no national standard on how much face-to-face you should offer. The Royal College of General Practitioners are working with the British Medical Association on some guidelines on that for the end of next month, which we'll wait to see. But I doubt that they'll be able to give us a precise figure. It's really about the mix of having a mix of ways to see patients and a mix of staff to see them, as I've said. And really, there's a benefit in making sure that only the people who need to see a GP see a GP. It's estimated that about 80% of people want to see a GP or a GP or do see a GP. Actually, only about 20% of those people have the kinds of conditions that actually need to see that level of expertise. Many of those people could equally well be seen by an advanced nurse practitioner, a physiotherapist, a nurse. So there is, as I say, benefit in a mix. We will, I think, see COVID restrictions, as we see COVID restrictions ease, as we see things go back to normal. There will be more face-to-face appointments, and I think that's what general practice themselves want, obviously what patients want, and we will start to see that. As I say, a mixed approach would be one that the national strategy would recommend and the one that we've been following. Next slide, please. In Derby, it's obvious we have, and we've talked about, I've been here before, we've talked about this before, access for patients, demands on practices is a major concern. It's a major concern for patients and for practices. We have started this month to see information at a practice level. Up to then, we didn't see information regularly monthly, but for the first time this month, actually last month, 14th of October, we got some practice level data. We do get a national survey. The survey shows mixed levels of patient satisfaction. We've got some excellent practices which are showing outstanding levels of satisfaction, others where they're below the national average. The key concern that people have in the survey, and it's one very familiar to us, I think, is about their ability to get through on the phone. People tend to be happy once they're through, but that process of getting an appointment is the challenging one and the one that people are most concerned about. Next slide, please. I think there is a misconception that practices have knocked off, are working less hard. Actually, as I hope I've shown, they're working harder than ever. They're offering more appointments than they did before the pandemic. They're offering more appointments on the same day. They're obviously following COVID rules. They're doing COVID vaccinations. So in Derby, GPs have done 75% of all the vaccinations across the city. At the same time, catching up on the backlog of patients, particularly those with long-term conditions who they may have missed and had to catch up. The other thing I think worth noting, I'm sure you're aware, is that obviously GP services are part of an overall programme of health and social care. They don't operate in a vacuum. When people are waiting in hospital, waiting for long waiting, there are long hospital waits. When there are cuts or reductions in other services, all of that increases demand overall on general practice, which will obviously impact on access. Next slide, please. There are a range, and I will go through all of these, but there are a whole raft of national and local initiatives to try and improve GP access, increase the workforce, add in additional appointments, recruit and retain staff, develop nurses and other staff, reduce unnecessary admin, improve digital access, and review telephony to try and improve the kind of technology. Next slide, please. The other couple of things I would say, and this has been changed now, there's a national winter access fund this year, which will bring in additional funding to general practice in Derby. But as well as that, there's an investment in impact fund. And on the next slide, I think, if you just jump to that, there's also funding for what we call additional roles. So this is part of an overall national strategy. In Derby, the primary care networks, which are the groups of practices, will effectively get nearly £4 million to invest in additional non-GP or nurse roles by March of 2024, which equates to approximately 140 full-time people. Next slide, please. Just a few points about the practices and what's happened over the pandemic. We haven't decommissioned any services. We didn't pause any because for any other reason than IPC, infection prevention control. In fact, we're looking to increase the number of services that we commission. Some services, as I mentioned, like spirometry, which is the test you have when you have to try and diagnose asthma, were temporarily paused because it was recommended by the senior clinicians nationally because of the risk of COVID transmission. These are now being picked back up. There's a backlog, of course, for checks on some patients with long-term conditions, and we're prioritising those most at risk. Demand for flu, demand across the system is very high. As I say, flu is likely to be 50% worse, and childhood respiratory illnesses have also seen a significant increase. Next slide.
Sorry, I think we're losing you a little bit. Thank you.
Oh, sorry, I'm just leaning back, obviously, sorry.
Doesn't record, and we're live streaming, so if they can't hear you, if you're not into the mic, we did hear nothing, but thank you.
Okay, sorry. Next slide, please. Yes, so to sum up, and I can talk a bit about the new national policy in a minute, probably in response to some questions, but access is very challenging. Demand for general practice is surging at the moment. Practices are working harder than they have ever done in terms of the number of appointments offered. We are seeing a different mix of appointments at the moment because of the pandemic. Satisfaction with access is very mixed. There's ongoing work to improve access by practice, and again, I can talk about some of the work we've just launched as part of the new national approach. Staffing remains a challenge. We're not cutting any GP services. In fact, we've got a proactive approach to commissioning more general practice services, and we are expecting, but I suppose we're expecting demand and pressure on staff is likely to be very high over the winter, and we are increasingly concerned about practice staff well-being. There has, as some of you may be aware, been some high-profile examples of abuse and, in fact, violence and aggression towards practice staff, including in Derbyshire, and the police have just been involved recently last week, in fact, in another example where threats were made directly to practice staff in Derbyshire. So it's a concerning picture, but as I hope you can see, we have some detailed information about it and a plan.
Right, thank you very much. Councillor Froggatt.
Hi. Before the pandemic, the only contact I had with my GP surgery was online. I never phoned them. I rarely went to visit them, to be honest. We did everything online. Tweaked my prescriptions, made appointments if I wanted them. I have the NHS app. And on my surgery website, it says, online is not accessible and please do not tweak your prescriptions as this site is not monitored. So, you know, why? I mean, and when you ring up, obviously, you're on for ages because nobody's answering, so you just give up. You know, people are actually sitting on illnesses because they can't get into the GP service. I know people, and I've begged them to go, with moles and melanomas and God knows what. There's somebody with a very bad chest infection. They just keep going to the chemist for some medication because they cannot get through. But why they are not letting you access online, I have no idea. I've asked the question, and all I've been told is, well, that's what we're doing at the minute. You know, so why? Are they still hiding?
So the standard operating procedure changed during the pandemic to move away from online, effectively to cut down channels to allow a kind of a more focused approach. And practices were encouraged to use the phone more. Practices are now, that's been relaxed, so practices can move back. And what they're trying to do, I think, and I don't know about your practice particularly, but some practices have adopted an approach where they're maintaining phone first and triage first. Others are moving back towards more of an online approach or a mixed approach. It is a bit confusing. The guidance has changed several times as advice changes. And it's just changed again recently with the last advice that was issued in October. So it may be that the practice is just trying to catch up with the advice, work out the best approach, manage its capacity. Obviously, you know, it's not ideal. I expected you to say, I used to be able to see face-to-face, and now I can only go online. And that's quite common. It sounds like you've had the opposite experience where it used to be online, and now it's all face-to-face, which I think is probably an example of the practice. And again, I can't speak for this particular practice. I don't know which one it is. It's probably the practice trying to adapt and then needing to adapt back. And it will change. It's a very unusual moment, I think, because although we're coming out of the worst of the pandemic, we are in the kind of grip of a real surge in activity and demand, and it is causing practices a great deal of stress. So they're not perhaps as kind of adaptive as they have been. And the other point you made that for some people and some practices, the actual difficulty in getting through is a barrier to good healthcare. I completely accept. I think that's absolutely right, and clearly part of your experience is being able to get through. And if you feel like you're going to have to fight to get your appointment, then it's a natural barrier. And if you're not, you know, if you're just trying to avoid it, trying to ignore it, as you say, it worsens, doesn't it? I completely agree, and I think that's why we're putting a lot of effort nationally. They're putting a lot of effort into trying to open up appointments, open up capacity, improve telephone systems. Yeah, that's it. I think there are some structural, as we've talked about before on this, there are some structural issues around staffing and capacity, phone systems, about, you know, small businesses effectively trying to manage surges in activity. It's very hard for them to do. Yeah.
Okay, thank you very much. Councillor Lonsdale. Councillor Herasain was first with you. Sorry, I guess with Emily sitting at the side of me, I can't always judge a bit. Sorry, Councillor Herasain.
It's not a problem. To be honest, I don't know where to begin, because in my view, some of the problems were actually deep-rooted as far as GP surgeries were concerned before we knew anything about the COVID. And since COVID, things seem to have got worse and much worse. Both my personal...
Sorry, Fareed, could you talk into your mic? Because for Councillor Froggatt can't hear you and she's sitting behind you. Thank you.
My personal experience and talking to constituents, I get the impression that most of my constituents feel in complete despair. They're only praying that they're not taken ill, because vast majority of them are saying, when we need to contact our doctor, it's impossible to get through. It's impossible to get an appointment. And generally speaking, I can give you an example. personal example. I had a small infection, and I was trying to make an appointment. First day, I rang up and said, today we've got no appointment, try first thing in the morning at 8 o'clock. I rang at 8 o'clock. I eventually got through to somebody at 3:30 in the evening. In the meantime, in the morning, I tried 39 times. I made a no, because after a bit, I was just clicking. Anyway, at 3 o'clock, I spoke to somebody, and they said, obviously, there are no appointments for tomorrow. I said, what about day after? It's not emergency. I just need to see somebody. Even if you've got an appointment in 10 days' time, it's not urgent. I just need to, They said, no, you have to ring in the morning at 8 o'clock. I set an alarm clock. I woke up at 7:30, and I rang 1 minute to 8. The answer phone hadn't been taken off. By the time I'd done it, the answer phone, a minute later, I rang again. And the answer phone came on and said, all the appointments for today have been taken. And it's not just me who's had that problem. I hear the same stories from many, many other people. The picture that you painted presents a little bit normality returning and things getting better. I'm not picking that up when I talk to people in the street. The other thing is, which worries me, I read a survey about a month ago, maybe 6 weeks ago, where they published performance of all the practices in UK. There were about 10,500 in total. Derby came out of those surveys quite bad in my view. 3 practices in Derby were in the bottom 200, which was unique to Derby because in most of the city they had probably 1, maybe 2, but a city size of Derby, 3 practices were in the bottom 200. I don't know whether you saw that survey or not. And I thought, well, it's not just my practice which is struggling to provide services. Obviously, there's lots of other people, because it was all based on patient feedback. The patient survey. Yeah. That's right. The surveys were based on the information which had been given to the surveyors on the phone or whichever way they contacted people throughout the country. So we've been complaining about struggling to get GP appointments. Things have got worse. It's, as I say, why can't they, least they can do is they can book next day appointment or day after. Why have they ripped up those diaries and thrown them away and say, you've got to ring in, today's appointments have been gone. They've all been taken. Ring again at 8 o'clock again. You do that, and the day after, why can't they just book it a week in advance, 10 days in advance? Why isn't the system allowing them to do that? Do they want to make life very, very difficult for people who are struggling? And secondly, if they want people to make appointments using internet or whatever diary, why can't they send a link and say the best way to make an appointment is go on this link, click on it, and it'll take you through, and you'll be able to make an appointment on internet. No information, you can't get through to anybody, you can't speak to anybody. And generally speaking, I am despairing, honestly. I've been in this country 52 years. I've never seen National Health Service generally struggle as much as it is struggling now. And there is no point anybody trying to pretend, that things are getting better, we're getting somewhere. Things are being deteriorated, and they've got deteriorated to the extent where despair, genuine despair is setting in. Hopelessness.
So, your experience sounds terrible, and it sounds like you're in a kind of like a purgatorial loop, don't you, where you can never get out, by the sounds of it. And I've had that. I've heard of that experience to other people. Obviously, again, I don't know your practice. I think what the practice is trying to do is balance their demand against their capacity. They try to make sure they've got enough spare capacity for urgent, in inverted commas, same-day appointments with the appointment, and that can sometimes mean that they like to block out chunks of same-day appointments for urgent work, which limits their ability to book ahead. And that balance of urgent and non-urgent with limited capacity puts them into this loop where, as you say, your experience is one I've heard as well, and I've experienced myself, where you're forced to ring on the day. We are working with practices. There's a national program called Time to Care, which looks at the way they organise their appointments and works with them on trying to match the capacity they've got with the demand, to make sure they're not, as you just described, just blocking people effectively. A lot of this, I mean, I've been in the health service a long time and in this area quite a long time. A lot of this arose from national targets, a couple of decades ago now, where we were set national targets around practices, people being able to book within 24 hours, which effectively meant people closed down their appointment systems, and they never properly adapted them back because they're so concerned about managing their overall capacity. But I think your point is well made. A lot of the problems are structural. This won't be a practice that likes blocking patients. It'll be a practice that's struggling with the demand against the capacity it's got. And it will be a practice that's actually so in the trenches with this that it's not really had a lot of time to think about how it might better organise or even to bring in other people to help. So I know it's a difficult situation, and I think the other thing I would say is that practices are different. I think you've got practices in Derby where they've got very high levels of access and people can get in relatively easy, and the satisfaction seems very good, and practices where people really struggle. So it's not it feels universal when you're on the end of it, of course, but it isn't a universal picture. And in fact, the national data that was published this month showed that of the bottom 20% of practices, according to this national data set, only one was in Derby. In the county, I mean. So of the 112 practices we have, of the 25 that were seen as the worst against this set of national indicators, only 2 were in Derby. One was in the kind of top 15%. So, but I think any data you've got really doesn't reflect patient experience. Do you know what I mean? We haven't got brilliant data yet on the data and the patient experience.
Okay, thank you. Councillor Lonsdale?
Well, mostly it's to echo what my colleagues have said, that it is incredibly difficult to get a non-emergency appointment, particularly like in my personal practice. You have to phone up at 8:30 if you want an appointment at all. It has to be a same-day appointment, so those of us who have not so an emergency need feel guilty about phoning at that time in the morning, because you know that's what the time when you're supposed to call if you're an emergency. Is there a encouragement being given to these practices to release release some appointments that people can phone later? It's not very convenient for families or elderly people who maybe sleep past 8 o'clock. It's to have to phone at that time and wait for ages on their answer machines, and sometimes to be cut off as well. Yeah, no, I know, and as I say, I've had that experience personally. The practices are independent businesses, and how they manage their appointments and their capacity is a very operational thing that they do. So we don't have a rule. We can't say you've got to release this many, you've got to open up this. That's not how the contract works. That's not how the service works. But clearly, we don't want to get to a position where they're blocking as many appointments, so many appointments that people can't book ahead. And we're strongly, and as I said before, that there's a time to care program, and then there's focus on practices who are struggling the most to look at how they're releasing appointments, and to strongly encourage them to release those appointments. As I was saying to your colleague, this is about the practices trying to manage the capacity and demand and trying to keep the appointments available for people who do need it, with the structural problems that they have at the moment of relatively low levels of staffing, some of them. So they're just trying to manage quite a precious resource in terms of their overall capacity. But I agree, it's not an ideal situation.
Thank you.
What things... On another note, what we're putting in place to support the GPs and the practice staff with their mental health and they seem to be under a huge amount of pressure. If they're getting attacked and verbally abused and things, are things getting put in place to support them?
Yeah, we have a GP task force that we work with, that we fund, and their role is part of their role is looking at staff wellbeing, and we're part of a national pilot supporting practices and individuals with that wellbeing. We're also doubling up on our communications with the public and with patients to try and explain the situation at the moment, to try and tone down some of that sense of frustration and anger that people are feeling to reduce that abuse. And we work individually with practices who struggle and report abuse. We've just launched a kind of premises and estates fund to support practices to manage their estate so that their staff are protected. It's not an ideal situation, isn't it? But to try and make sure people feel safe. So it is difficult, and we're doing what we can, I think.
Thank you, Councillor Grimmadale.
Thank you, Chair. It's a very general question. There's a statement. Why do we believe that flu is likely to be 50% worse than a normal year? I mean, what stats have you got to back that up?
They're not my stats. It's the national epidemiological modelling. I think I'd have to come back to you with the detail of that, or public health team perhaps here could explain that to you. My understanding is effectively it's the suppression from last year, the fact that people none of us been out as much, we've been wearing masks, we've been isolating, has meant that the flu season has been significantly less bad last year. So therefore, we didn't build up the kind of natural immunity in the community, which means that this year it's going to be that much worse. And the same for paediatric respiratory diseases. We are anticipating, we're already seeing an uptick in all of those because the kids who would normally get them in any given year didn't get them last year and unfortunately are all getting them this year. Well, it's an epidemiological model based on public health data. I'm not a public health consultant. I couldn't tell you the detail of that, and it may not be 50. I don't. It's a model, so it may not be exactly 50%. But I think they're talking about in that range of a significant increase in that.
Okay, I have a few comments, thanks. Thank you for bringing the report. I mean, I think we do understand that all of the health service is under a lot of pressure for a whole number of reasons, and I think probably most people believe that GPs and practices are doing their best. We do note their level of independence they have, though, which makes it more difficult for people like you to intervene and introduce something systematic. And a comment I would make is that in some respects, it's good to have flexibility in the GP service and the way they practice and they run, but it does become quite complicated for patients. There's this whole, and it's more difficult for you to make proposals, I'd suggest, that actually bring in some systematicity to the situation and some rigour to actually improve things from a kind of citywide perspective, talking about Derby at the moment. So I think that is a slight weakness in the system, but I know it's not one you created. So, but I do think there are some. I think everybody here is saying a similar thing. I don't know if you can assume that I don't know about Councillor Grimmadale, but I think there is on the one hand there's an element of sympathy, but because we know some of us believe that the NHS has been underfunded for 11 years, and we know that you're under pressure, and we know that there's a shortage of GPs, and we are where we are almost. But on the other hand, I think we need to impress upon you from this board the sense of, as Councillor Hussain said, the sense of desperation that people feel, the difficulty of access, the complexity, the absurdity of it sometimes, and the completely humiliating process of putting yourself out to try and get a GP appointment and then, say, waiting for 30 minutes on the phone, and that phone, your call being ended because nobody's able to answer it. And for somebody with suffering who's ringing up a mental health issue and is feeling depressed, that is really, that attempt to reach out for help by being on the phone, to have it's really dangerous, I would say, in those particular circumstances. So what I think really it's so late, everybody must be getting tired. I know I am, and I appreciate you must be, because we know that your jobs are demanding. But I think that there is a demand out there. I think that my view is that it's important to have a mix, as you say. Some people do value these phone calls, being able to send in a photograph of a problem. But I think what perturbs me about some of that, there's an awful lot of self-diagnosis going on. And so, you know, and when you're triaging, who you're talking to, a receptionist, how on earth can they judge? I mean, because I've known many physiotherapists who said, well, we get people, and that was sent by the GPs then, who were saying they sent them with back problems, and actually their husbands just left them. So the truth that, you know, actually getting to the bottom of what people's problems are, providing them that interpersonal reassurance, which is, I mean, I've heard it said it's 50% of medicine. Is that empathy, is that being with the person. And I know this must sound like some idealised world I'm talking about with the pressures you're under, but in the long run, that kind of approach of interpersonal interaction, listening, face-to-face, that sometimes that does save time, because you're actually getting to the real problem rather than just signposting people to a load of very expensive tests sometimes, like I've had, for example, which I won't bore anybody with any details about. But, you know, so I think there's a whole issue here about the nature of the practice and what is most efficient and etc. But and I do think there should be more face-to-face appointments. Because I think that is what people want, not only just face-to-face, but more face-to-face. And I have read the BMA's response to the government's demands on that. And I know that the BMA took the view that it should be strictly down to the clinicians to decide whether somebody is due a face-to-face appointment. Well, I would actually just like to note that I don't agree entirely with that. I have recognised that some people don't need to see a GP face-to-face, but I think that you cannot predetermine outside of seeing them whether that is truly the case. If you're doing, I mean, occasionally you can, but often you can't. And I'm worried about who's doing the triaging. So I don't know if you want to come back on any of that, but I do have a recommendation.
Probably only to say I think your view is probably shared by the majority of GPs. I mean, they didn't go into general practice or into clinical care to work in call centres. So I think they would be, and they are keen to see people face to face. That's what they like to do. I think it's a balance, isn't it? I think general practices, GPs particularly, are always going to be a limited resource. They're the top of the tree. They're the specialist really in the community. So we do want them to see the most complicated people, and you know we do need to stream some people away from them in order to free up their time to do that. But you're absolutely right. It has to be done carefully, and there has to be ways back to them if it's felt actually they did need to see a GP and they've gone through the wrong door in the first instance.
Okay, so do anybody else want to come in with any final comments? Okay, I'd perhaps like to us to have this. Perhaps, I don't know if you agree with this sort of recommendation or point to note for Mr. Newman to take back to the CCG. How about if we say we recognise that GP practices are working to improve access, but we urge the CCG to act urgently and systematically to improve GP access in accordance with your own plan and to increase face-to-face appointments. Is everybody happy with that? Thank you. So the point is,
Instead of all GP practices, can we say most GP practices?
Most GP practices are working, okay. Okay, yeah. So we recognise that most GP practices are working to improve access, but we urge the CCD to act urgently, and that's the put stress here, and systematically to improve GP access in accordance with its plan and to increase face-to-face appointments. Is everybody happy with that? Okay, right. Well, thank you very much for your time, Clive. And no doubt we'll be harassing you again about this issue, because it is the key issue that is really is one of the key issues that are really concerning people at the moment. Thank you.
Noted. Thank you.
Right, finally then, very quickly, because we have been a long meeting and I thought it would be shorter than this. Very quickly then, our work programme and topic review. So I just report back on the topic review. We've had one meeting where and there were quite a few of us in attendance actually, all apart from Councillor Grimmerdale, so I won't go over that. We are going to have a series of others. Lindsay's just in the process of finalising some of the dates and times with a whole series of people to talk to, and also to write we're finalising a letter to send out to care homes. And we have a plan that Lindsay's very well put together. Thank you, Lindsay, on that. So it's sort of it's ramping up from now on. That. So is everybody happy with that? Yeah, good. No questions on that at the moment. Good. Thanks. And then on the work programme, we have quite a full work programme. We have another meeting at the end of the month, as you know, which was an additional meeting to the ones that we normally do for this board. Does anybody want to add potentially anything else to look at adding that to the work programme now? Did you, anyone? Do you want, Councillor Lonsdale?
The thing I was interested in finding out was adult special needs, how quickly are people getting diagnosed if they're trying to get diagnosis with like ADHD or ASD or anything like that? I don't know how other members of the board feel about that.
Right, thank you, Councillor Lonsdale. We'll ask for a report on that then to fit into one of the later meetings in the year, because the next two are very full. So, thank you. Right, no further comments? Okay. Well, thanks very much. Been a really interesting meeting, and the meeting is now closed. Thank you, and thank you, Lindsay, for your.